change topics a bit to a little more congenital, but also with a big adult spin. So PFO and the questions that remain unanswered and questions that trials do not address.
Okay. In this slide, I tried to summarize, which is in fact a recent meta-analysis, where we are. As you know, in terms of PFO closure, the 3 last randomized trials have shown really a significant benefit in terms of prevention of recurrent events associated with PFO closure in young patients with cryptogenic strokes. You all know this data, and we are now going to more specific aspects that maybe were not covered in these trials. First of all, the trials had a mean follow-up that was at the maximum of 5 years. There are patients with more years, but as I'm talking as a mean follow-up, most of them had 2 to 3 year follow-up, which is relatively short. Here we are talking about 40-year-old patients. Patients' age in these trials were younger than 60 years. We all receive requests for patients that are 65, 68, 70, in good shape, etc. But these patients were not there. Something that I talk about this at least 2 times with Eric about the need of lifelong antithrombotic treatment in these patients. This is a very frequent question that also we have, these 30-year-old patients taking aspirin for life. And then patients with thrombophilia. This is not such an infrequent problem. We will go first for the long term. This is a study with a 200-patient cohort from our center with a median follow-up of 12 years. Minimum was 10 up to 17 years. Very standard group of patients as in the trials, in patients in the 40s with a relatively low rate of prevalence of cardiovascular risk factors. As expected, good results with the closure. Vast majority of patients received an Unplatzer PFO occluder device. And these are the results at up to 15-year follow-up. As you see, the stroke rates were extremely low, 1%. This appears, it could appear like, wow, it's very, very low. But remember that CLOSE, the French study with different devices, etc., was 0. Was not a single stroke event in the PFO closure group in that trial. And then when you combine for sure with a stroke or TIA, you increase a bit the numbers. But the numbers, the good news are, seem to remain very low over time, as reported by the randomized trials. What about patients that are older than 60 years? In fact, we had one study like more than 10 years ago saying that the same type of phenomena that we observed in younger patients, which is a higher prevalence of PFO among these patients with cryptogenic stroke, occurred also in patients with that were older than 55-year-old. And then I think that there was not this was not very well followed, I would say. It's like this was there. This started like this, as you know, in the younger patients. It started with a higher prevalence of PFO. But as I said, there has not been a lot of interest in older patients. In a cohort of close to 500 patients from our center, we had close to 20% that were older than 60 years. For sure, these patients have more cardiovascular risk factors and a much lower ROPE score, which is the index trying to determine whether the stroke is related to the PFO or the PFO is an incidental finding. And the higher you have the ROPE score, the more likely is that your PFO is the responsible for the stroke. The lower is your ROPE score, increases the likelihood of an incidental phenomenon. And in this group of patients, and after an adjustment for these differences, we observe really for sure these patients die more frequently. Most of these deaths were related to cancer issues. the follow-up of this cohort was about 8 years as a mean follow-up over 5 years. And then in the adjustment, we didn't see major differences. However, you see some tendencies towards a higher rate of stroke, TIA, and especially the combined. It seems to be like as much as twice the rate observed in these patients. Also, you have a more, at least in the unadjusted analysis, more rates of atrial fibrillation. Sometimes when we discussed about this study, we said, well, maybe these patients, we have to be more strict in terms of the ECG monitoring before the closure. Is 48 hours enough? Should we monitor these patients a bit longer? Because definitely it seems to be a higher rate of atrial fibrillation in the years following the PFO closure. This being said, it seems that according to at least to the expected rate of stroke, according to the ROPE score, we are much lower than this expected rate in this group of patients. Again, this is an exercise that has been done a lot in LA closure, etc. It's not perfect, but at least it's like a kind of a promise. And I think that more studies need to be done in this group of patients, because now that we are receiving a lot of patients for PFO closure, it's very usual that the referral doesn't look exactly at the age and says, is a patient in good shape, and that's it. I don't find anything, just close the PFO. And then the issue of duration antithrombotic treatment. One of the things that we observed in this very long-term follow-up in our group of patients is that bleeding events exceeded, in terms of incidence, the rate of ischemic events. And all these bleeding events, or the vast majority, occurred under aspirin treatment. In fact, there were even 4 intracranial bleeding issues. One of them was terminated with death, meaning that it's not very surprising. We know that in primary prevention, in secondary prevention, taking an antiplatelet for life increase your likelihood of having a major bleeding event. And then, what's the rationale behind that? For sure, the rationale would be, what if the PFO was not the responsible? Here is a study that we published 10 years ago, comparing young patients with PFO, without PFO, and then a control group. And we had other measures of atherosclerotic burden. And as you can see, this population has the same, really, we did also endothelial dysfunction, another test, and this population was exactly as the control group. Whereas the patients without a PFO had much more cardiovascular risk factors, and the atherosclerotic burden was much more important. Mechanistically, but it goes in the direction of saying, look, it seems that really these patients are in good health in general, at least at the same level of the general population of the same age and gender. And then again, when you, this is the ROPE score calculator in order to identify, as I said before, stroke-related versus incidental PFO. The highest you are, if you have 10 points, is sure that the PFO is the responsible for your stroke. And I would say over 6, 7, it's really highly likely that your PFO is responsible for the stroke. We evaluated again in a cohort of close to 500 patients, those patients who stop antithrombotic treatment, mainly because of individual reasons, because they decided to stop. Sometimes the referral stopped the treatment, sometimes was a misunderstanding, etc. There were 80 patients that at a mean of 6 months after PFO closure stopped the antithrombotic treatment. And we had a follow-up of these patients that was over 5 years, close in fact to 10 years. And the good news are that in these patients that I have to say, as you can see, were younger, had less cardiovascular risk factors than the ones that pursued the antithrombotic treatment. But in this group, we didn't see any ischemic event. up to 10-year follow-up. It's a small cohort. This is the propensity match where the cohort was even reduced because of that, but we didn't observe differences in those patients who at 1 year follow-up were not receiving antithrombotic treatment. And with this preliminary data, I would say, and with the data with the very long term, we are planning to start really on a study trying to evaluate in a rigorous and prospective manner the discontinuation of antithrombotic treatment in these patients. The patients will be treated for 1 year as a standard. Then for sure we will look for residual shunt, no severe cardiovascular risk factors, no diabetes, no thrombophilia. And then these patients, there will be a cessation of the antithrombotic treatment. There will be also a cohort with MRI. We have talked about this with Eric, and I hope that could be a good opportunity probably to do something as a network study regarding this particular issue, because now I'm sure you are receiving a lot of patients, and this is something that is very frequently asked. And they have had a stroke, but we are closing ASDs, and we don't see any kind of embolic issues or ischemic issues at follow-up. And very briefly, in 1 minute only, to talk about the thrombophilia patients, because this group of patients were not included in the trials either. This represents 10 to 20% of PFO. I don't know about your referrals, if this these type of tests are performed before, but I think that it's important. It's important because the studies go between 10 and 20% of these patients have different types of thrombophilia. As you see in the randomized trials, it was a mixed. In general, they took into account this problem and tried to exclude patients, but there were some differences between the trials. There have been some studies, but you see the number of events is ridiculous. You cannot say much. Some studies suggesting that when you have thrombophilia, you have a higher rate of recurrent strokes. Others saying the contrary. In our study, there was also a tendency towards a higher incidence of cerebrovascular events at a very long-term follow-up. Among these patients in our study, this represented 15%, but not all patients had this test performed before PFO closure. I will end with this slide. PFO closure is a well-established therapy for young patients with cryptogenic stroke. I think that older patients may also benefit from this therapy. There is a need for more studies regarding the optimal duration of antithrombotic therapy, with the bleeding and ischemic issues that we have been talking. And then the presence of thrombophilia, I think, may increase the risk of recurring events in these patients. Thank you very much for your attention.